Hi everyone, how are you all doing? A very good evening, and I welcome you back to the FARRE batch. And all right, Achintya, very nice to see that you're ready to stay in the game, and you guys have stayed in the game for the whole year, and this is the final push. Of course, the exams are knocking on the door, and that is why FARRE is here. And today we are going to discuss bloodstream infections. Good evening. Very nice to see all of you joining here and of course interacting in the chat box. Please keep interacting, please keep answering, please keep asking questions. I shall address each one of them. Today the major topics that we are going to cover are these guys. Okay, majorly we are going to cover bacterial and viral bloodstream infections, because in the FARRE 2025 I have already covered enteric fever, which is typhoid. I have already covered all the parasitic infections. Okay, so it included malaria, it includes leishmaniasis, trypanosomiasis, and also filariasis. So all of that has been covered already. So on popular demand, you guys had said that please cover the topics which were not covered in previous FARRE series. So that's why I'm going to cover these ones. Okay, they were not covered then. So today we are going to cover them. Right. So we have infectious endocarditis, mainly focusing on bacterial infectious endocarditis, right? AC chala dena please. Then we have FUO, fever of unknown origin. Very important short note, long note. On Monday, oh uh, good luck to you, because it's still pre-prof. By the time your prof comes, you will be very well prepared. All right, then we are discussing infectious causes of anemia, right? Infectious causes of anemia are short note in itself. Of course, the very important HIV, AIDS, all the viral hemorrhagic fevers, especially the dengue, chikungunya, Kaisanur forest disease, all the important viral hemorrhagic fevers. Among spirochetes, we are going to read about Leptospira and Borrelia. Okay, so the important species of Leptospira and the two important groups of Borrelia species, and of course the rickettsial group, the very famous rickettsial group, including scrub typhus. So the rickettsial fevers as well as scrub typhus is what we're going to cover. So it's going to be a long lecture. It's going to be detailed lecture. Of course, as usual, we are going to read in the way you're going to present in the exams. So in a handwritten format, in a crystal clear and clear format. Okay. So when I say bloodstream infections, of course, there are some important terms that we need to know. So what is bacteremia? It is the presence of bacteria in the blood. That's it. Bacteremia. Emia means blood. Bacter means bacteria in the blood. Then you have transient bacteremia. This means that bacteria just comes in the blood for a short amount of time, and then it goes away inside the organs. Continuous bacteremia means continuous release of bacteria. Example in infective endocarditis, because all the blood is coming from the heart, and if the heart itself is infected, then the organisms, they keep coming out in the blood continuously. That is continuous bacteremia. So that is what you're going to write about bacterial endocarditis. Intermittent means intermittent release, such as happens in relapsing fever. All right, that intermittently bacteria releases, then go back hides inside, then again it comes out. Septicemia, on the other hand, is a totally separate terminology. Okay, septicemia is totally separate. What is septicemia? Now the bacteria is multiplying and it is releasing the toxins. Up till here, it was only existing in the blood. It was just bacteremia. It was just bacteria existing in the blood. Now it is releasing toxins, it is multiplying, therefore it is leading to an inflammatory response from my body, right? So if you see in a normal blood, if just there is bacteria, that's bacteremia. When this bacteria starts releasing toxins, it leads to septicemia. And when these toxins go and start attacking different organs, now the clinical features which come is sepsis. Okay, sepsis is the clinical symptoms of this septicemia, and finally it leads to septic shock and organ failure. Shock, of course, means reduced blood pressure, so much so that the vital organs are not even receiving blood. Good evening, Vaishnavi, nice to see you. Right, so this is the difference. This is the way in which the things progress. When I say bloodstream infections, they of course can be bacterial, viral, parasitic, and fungal infections, right? Like I said, parasitic sporozoans, hemoflagellates, as well as lymphatic filariasis has already been covered in the FARRE 2025 on the lecture title Protozoan Bloodstream Infections, and opportunistic fungi and Gammophobic is what is going to be your homework today. So we are going to read these major guys, a big group, which is, viruses, especially HIV and viral hemorrhagic fevers, and important GNBs, spirochetes, and the rickettsial group. I'm very good, Munir. How are you? Nice to see you. Chalo. So this we have seen already. Now we start talking about bacterial endocarditis. First of all, you need to know that it is infection of the endocardium, not of the pericardium, not of the myocardium, but the endocardium. That is why endocarditis. The great vessels of the heart that it can include are aorta, pulmonary artery, you know the drill. It can be device related and it can be autoimmune mediated also, such as acute rheumatic fever. So the reason that the heart valves or the endocardium of the heart is getting infected is maybe because the infection is coming from outside, such as through catheters which are placed, or inside like a immune reaction that the body is giving. Good evening, Rafi, good evening. When I say infective endocarditis, the microorganisms generally infect the heart valves. So what is the pathogenesis? Then the next step you will write is the pathogenesis. Of course, there are some predisposing factors. What are the predisposing factors? There could be a prosthetic valve which has been placed inside. There could be a damaged heart valve. How do the heart valves get damaged? For example, IV drug abusers. The IV drugs are crystalline drugs. So those crystalline drugs, they go through the bloodstream and they cause friction against the endothelium of the blood vessels as well as of the heart, therefore damaging the heart valve. So it could be a damaged heart valve, it could be a prosthetic heart valve, and it could be a normally healthy heart valve, but the person is highly immune prone to getting infections. Okay. Yes, you will be receiving the notes. So this is epithelial, then the epithelial injury or the valve damage happens. In the valve damage, in the rough surface of the valves, now damaged valves, the bacteria are going to get implanted over there. Okay, when they get implanted, that is the colonization by microorganisms. Colonization simply means you're sitting there, you've made home there. Okay, now it's colonized, it has made a home, many people have come together, and when these bacteria, they mix up with the platelets and the fibrin in that area, that is what is called as a vegetation. So what is a vegetation? Now these microorganisms, along with the fibrin produced by my body to control them, the platelets which get attached to this damaged endothelium because of course the Weil-Willebrand factor and all that is pathology. So that entire conglomerate is called as vegetation. Now these vegetation, see, this is a heart valve and there is a vegetation on top of it. So you can make these simple sketchy diagrams. Simply make a W-shaped structure, tell that this is a heart valve, make a mixture of blood vessels, bacteria, and then make some few little fibroblasts in that, and then say that this is the vegetation, which is bacteria plus fibrin and the platelets. Okay. Now, a piece of this can also break off, just like a piece of it breaks off from a thrombus, a piece of this vegetation can also break off. And if that breaks off and flies away to a distant organ, that is called as metastasis. So, what is the metastasis happening of? It is happening of the septic emboli. I hope you realize. You have seen in pathology, embolus is of many types, and embolus can also be sterile or septic. So, this vegetative matter of the, infective endocarditis, this is a septic embolus, and this can fly away to different organs leading to complications. So, there, of course, there can be two types of bacterial endocarditis. This is what they ask you mostly to maybe make a differences table, or if it is a direct case-based, case-based question, in that also it is very important to make this differences table. We will stick to the dictum. Wherever we can make a comparison table, we will include it in the answer no matter how. Okay, so we are going to include this acute bacterial endocarditis and subacute bacterial endocarditis into the answer. So like I like to say that this is abe and this is sabe. Okay, this is abe and sabe. So which is the most notorious organism whom you would like to just give all the abuses, like abe tu kya karta hai, and then who is that? It is Staphylococcus aureus. So abe is quite an offensive word, and that is caused by quite an offensive bacteria which is Staphylococcus aureus, which is very virulent. Whereas you have the other guys who's sabe ke dil ka veer, sabe ke dil ka veer. Yes, Sabe ke dil ka veer. Who is that? Streptococcus viridans. Streptococcus viridans. Of course, yes, correct, Staphylococcus. Streptococcus viridans is less virulent. Why? Because it is a good guy of my oral flora. It is a good commensal of the oral flora. So think yourself, a bad virulent guy who has to cause abe does not need any special reasons to cause infections. Wherever it goes, it will cause infection. So there's a perfectly normal healthy person and a perfectly normal healthy native valve which it is going to infect. So the valve is going to be normal, it is going to be native, that is, it is not even a prosthetic valve, it is a normal natural valve of a normal healthy person, and this very virulent organism when goes there causes infection. Whereas this guy who is a good guy needs some special circumstances to turn bad. And what is that? That is a damaged valve. Whenever there is a damaged valve, there is a rough surface, this viridans is going to get stuck in that rough surface and lead to bacterial endocarditis. All right. So Sabe is going to happen by a less virulent strep viridans, and it is going to infect the usually damaged valves. Now it is subacute. So the next step is easy. The course of the disease here is fulminant and very, very acute. So it is going to spread very fast, whereas the course of disease here is going to be subacute. Yes, not a problem there. Of course, the onset also is rapid, and the onset here is also insidious. So this over here in Abe, the disease is going to start very fast and the disease is going to progress very rapidly. But in Sabe, it is going to start slowly and it is also going to progress subacutely or chronically very, very slowly. Okay. Now, what happens to mortality? Of course, something which is as offensive, as explosive as the word Abe is going to be highly mortal. So, it is very high mortality and here it is lower mortality. It is seen commonly in IV drug users and sometimes also prosthetic valve users. This can also be seen in the native valve of normal people. Whereas this happens in pre-existing valvular disease, and this specifically this viridans. Subacute means moving slowly, okay? Subacute, so you have acute and you have chronic and then you have subacute, which is in the middle, okay? So acute means happens fast, goes away fast. Chronic means slowly goes over for many years. Subacute is like it will start slowly and it will progress slowly, so it will take longer than what is acute, okay? So pre-existing valvular disease is going to be there, and one important thing to note here is there is always a history of dental plaques, dental abscess, dental plaques or abscess which will become the focus of infection. There might also be history of vigorous brushing of the teeth. So that is what is happening. The person is vigorously brushing the teeth, the person might have cavitations and it leads to little injuries in the mouth. Through those injuries, through the blood vessels, the bacteria is going, and then the moment it goes to the heart, it finds a damaged valve and therefore it goes and sticks there, right? Correct. Now, how are you going to diagnose? A very, very important modality of diagnosis is blood culture. Of course, it is a infective endocarditis. What is there in the heart? In the heart, there is blood. So, of course, blood culture is going to become your mainstay of diagnosis, is going to become the main laboratory investigation that you will conduct. Okay, and you have to set 2 sets of blood cultures taken 12 hours apart. This is the rule. So, one blood culture you will draw from the patient at maybe 12 a.m., another at 12 p.m. So, 12 apart, 2 bottles, 2 sets of blood cultures you have to send, and 3 or more sets need to be sent over 1 hour. If you don't have so much time, patient is not going to stay for 12 hours, then at least 1 hour apart you send 3 bottles of blood culture, and at least 1 set should come out to be positive in the lab for you to label it as bacterial endocarditis. So you're sending 2 sets 12 hours apart, or you're sending 3 sets 1 hour apart, and at least 1 set should come positive. What is the meaning of a set? 1 set of blood culture includes 2 blood culture bottles. 2 blood culture bottles, okay? Why are we sending 2 blood culture bottles? They have to be taken from 2 separate sites on the body. That is a set. One needs to go for aerobic incubation and one needs to go for anaerobic incubation, okay? This means a set. So such sets you have to collect 2 and 3. It does not mean 2 bottles or 3 bottles. It means 2 set of bottles and 3 set of bottles, okay? I hope you understand that. So what are the common pathogens? So like we have seen on a native valve, a very aggressive and virulent organism is going to come. Who is that? It is Staph aureus. Especially MRSA is going to be most common. What is MRSA? Methicillin resistant Staph aureus. Okay. So whenever it is normal valve, native valve, think of a very, very infectious and virulent organism, Staph aureus. If it is a prosthetic valve, then just think, how can a prosthetic valve get infected? So, a surgeon is going to insert the prosthetic valve inside the patient. What are they going to do? They're going to cut open the patient and they're going to insert the prosthetic valve. In the process of cutting open the skin, if the disinfection of the skin does not take place properly, then the commensal on the skin is going to go inside and infect this new valve that you have placed. Yes, who is the commensal on the skin? It is Staphylococcus epidermidis. The name itself is telling me that it is present on the skin, on the epidermis. So, a native valve bacterial endocarditis is caused by Staph aureus, especially MRSA. A prosthetic valve endocarditis is caused by the cons, especially Staph epidermidis, including methicillin resistant cons. The new terminology for cons is now OSS. So you can write MR cons or MR OSS, or you can write cons or OSS. More specifically, you have to say Staphylococcus epidermidis. Like I said, even in IV drug abusers, it is Staph aureus, and Sabe is Sabe Kedilkavir, which is viridans group of Streptococci. Right? Culture negative endocarditis. This is another group. So whenever you have bacterial endocarditis, you're sending these two sets of blood cultures 12 hours apart. The culture report will either say Staphylococcus aureus has grown, or they will say that the viridans group of Streptococci has grown. Okay. But sometimes the culture report is going to come out negative. Okay. Does that mean there is no infection? No. There are some organisms which are very difficult to grow on cultures. They are fastidious organisms. So the report will come out as negative, but they are still bacteria which are infecting. So these are culture negative bacterial endocarditis. So the statement might look like an oxymoron in itself. The statement might look like a misnomer, but actually they are bacteria. They are causing endocarditis, but we are not able to grow them in the lab. So that is culture negative endocarditis. Who's the most important group involved? It is HASIC group. HASIC group. What is HASIC group? Parainfluenza, Aggregatibacter, Cardiobacterium, Eikenella corrodens, Kingella kingi. Haemophilus, Parainfluenzae, Aggregatibacter, Cardiobacterium hominis, Eikenella corrodens, and Kingella kingi. So, it's easy to remember actually, whenever you say HASIC, just think of H for Haemophilus. You all know Haemophilus influenzae, yes, but that is going to cause pneumonia or meningitis. So, who will cause infection in the heart? What is present in the para area or periphery of the lungs? It is the heart. So, the guy who is going to cause infection in the periphery of the lungs, that is the heart, is going to be para-influenza. So, Haemophilus, para-influenza. Then all of these bacteria are going to come and aggregate in the heart valve. So, it is Aggregatibacter. You need not remember this. So, Aggregatibacter. Then these are causing infections of the heart of a human. So, Cardiobacterium hominis. Hominis means human, right? Then Eikenella corrodens. So, what are they going to do sitting there? They're going to corrode the heart. So, it is Ake. What did they do? They corroded. So, Eikenella corrodens. And then they have become the king of your heart. So, they are Kingella kingi. Okay. Just, easy to make it easy phonetically for you to remember. So, HASIC group, Haemophilus parainfluenza, Aggregatibacter, Cardiobacterium hominis, Eikenella corrodens, and Kingella kingi. Just repeating it so that it gets engraved in your heart, okay, in your brains and in your ears. Then we have to start talking about viridans group of Streptococci, which is going to cause SABE. What are they? They are the alpha hemolytic group of Streptococci. So, you know that Streptococci can be beta hemolytic group, they can be alpha hemolytic group, they can be gamma hemolytic group. Amongst the alpha hemolytic group, you have two important guys, the Streptococcus pneumoniae, which causes pneumonia and meningitis, and the viridans group of Streptococci. So, they all are alpha hemolytic. So, you can make a little diagram wherein you draw a blood agar and you show these colonies, and then you show that around these colonies, there is the little zone of greenish beta hemolysis surrounding these colonies. Okay. So, in the center, you have your white colored colonies. They are surrounded by this greenish zone on the blood agar, which is telling me that this is alpha hemolysis. So simple diagrams you can very easily make for these guys. Then they are gram-positive cocci in chains, just like all streptococci. They are alpha hemolysis on blood agar in the presence of CO2. They like CO2. Then we have always differentiated viridans from pneumonia, है ना? Pneumonia, good evening. What are all the features of Streptococcus pneumoniae? Optochin sensitivity, Quellung reaction, inulant fermentation, bile solubility, all of that is going to be negative here. So it is going to be optochin resistant. It is going to be not bile soluble. It is going to be identified by the automated system such as MALDI-TOF. So at least these two things you can say: optochin resistant and bile not soluble. That is viridans group of strep. How do you treat a case of bacterial endocarditis? If it is staph, you give clindamycin. If it is MRSA, of course, drug of choice is vancomycin or linezolid. Strep viridans needs penicillins. All streptococci ever till date, there is no resistance to penicillins. So overall, we realize that penicillins are more or less rendered useless by now because of all the drug resistance. But actually, streptococci are the one group of bacteria where there is no resistance to penicillins. So always for all streptococci, the main drug of choice is going to be penicillin. So of course, for viridans also it's going to be penicillin, and for the Hasek group, they are easily killed by ceftriaxone, the third generation cephalosporin. ठीक है? तो कैसे हम अप्रोच करेंगे बैक्टीरियल एंडोकार्डाइटिस का आंसर हम बात करेंगे शुरुआत में ही कि एंडोकार्डियम में इन्फेक्शन होगा. कैसे होगा? हाउ इज द एंडोकार्डियम इन्फेक्शन गोइंग टू हैपन? देयर इज अ प्रीडिस्पोजिंग फैक्टर सच एज अ डैमेज्ड हार्ट, देन हार्ट valve colonization of the bacteria happens, then they attach with the fibrin and platelets and make a vegetation. That vegetation can also metastasize and go as a septic embolus to other parts of the body. There can be two types of bacterial endocarditis, Abe and Sabe, and you know the drill of Abe and Sabe. Then you will tell that in the lab diagnosis we will collect two sets of blood cultures 12 hours apart. Either they will grow Staph aureus in a native valve, cons in a prosthetic valve, and viridans in a subacute bacterial endocarditis, or they will not grow anything. Reason being the Hasek group of bacteria which cannot be cultured but still cause bacterial endocarditis. Then you can tell a little about the viridans group, which is the alpha hemolytic on blood agar, optochin resistant and non-bile soluble. Treatment of course depends upon whatever organism has come out. So done and done. Okay, this is the flow, this is the format in which you remember bacterial endocarditis. Then there is something which is called as acute rheumatic fever. Acute rheumatic fever is an autoimmune disease. It is an autoimmune disease, but it is multi-system. Okay, don't think that it then your exam is quite far, Arushi. So you have very well time to prepare. So like I was saying, multi-system autoimmune disease, matlab it is autoimmune but it is multi-system. So don't think that it only involves the heart. So it is caused by an autoimmune reaction which is called as molecular mimicry. What is molecular mimicry? That the two molecules are mimicking each other. One molecule is trying to copy the other molecule. So usually a person gets a gas infection. Now it is not the gas infection that your moms get. It is the group A streptococcus infection. Matlab group A streptococcus is a beta hemolytic streptococcus. Yes, I hope you all know this. It is a beta hemolytic streptococcus which can be of two types, group A strep or group B strep. This group A strep, which is also called as streptococcus pyogenes, is the most important cause of sore throat or pharyngitis, especially the bacterial tonsillitis wherein you see the pus points forming. Okay. So, yes, correct, and protein. So, this streptococcus pyogenes causes a sore throat, and as a complication of that, the acute rheumatic fever happens. So, what happens? This streptococcus has a particular protein on its surface, and what is that protein called as? The name of that protein is the M protein. Okay, so the group A streptococcus has M protein on its surface. Then the body makes anti-M protein antibodies, right? And it goes and kills the bacteria. Now, the bacteria is gone, but these antibodies are floating about in the body. Wherever they will find an M protein, they will go and kill the M protein. Okay? So usually the proteins of our joints and heart and kidneys, they also have this M protein. So an antibody made against the M protein of Streptococcus is floating about in my blood. It goes and sees the M protein of the bone of the heart and of the kidneys, and it starts attacking them. That is the molecular mimicry and the autoimmune nature, that now the immune system is acting against my own body. That is autoimmunity. All right. So after around 3 weeks, it affects the heart, skin, joints, and the brain or the CNS, leading to migratory polyarthritis, Sydenham's chorea, Osler's subcutaneous nodules, pancarditis, and erythema marginatum. Now, how to remember this? To diagnose the ARF, you have the modified Jones criteria. And my students would know that our mnemonic for Jones criteria was cafe. It was Jones Cafe. The mnemonic for modified Jones criteria is Jones Cafe. So Jones is the major criteria and Cafe is the minor criteria. So what do you need to make a diagnosis? You need either 2 major criteria or 1 major plus 2 minor criteria, or evidence of previous gas infection. How do you get a evidence of previous group A Streptococcus infection? By doing the ASO titers. What is that? Anti-streptolysin O titers. All right. So yeah, we will just see about that. We have this coming up. It is called as anti-streptolysin O, which are the antibodies, and we will look for the titers against these antibodies inside our body. Okay. Thank you. So that is how we are going to make a diagnosis. अब देख लेते हैं criteria. Simple है. J for so this is the Jones criteria, which is J for joints. So joint means arthritis. So there is migratory polyarthritis. Now O kind of looks like a heart. So it is carditis. N stands for nodules. So you have the subcutaneous nodules, which are called as what? Which are called as the Osler's nodules. Subcutaneous nodules are called as Osler's nodules. Then E for erythema marginatum and S for Sydenham's chorea, which is the CNS. So joint भी involve हो गए, skin भी involve हो गई, heart भी involve हो गए, and your CNS is also getting involved. Carditis, and in the joints there is migratory polyarthritis. In the skin there is subcutaneous nodules and erythema marginatum, and in the CNS there is the Sydenham's chorea. What is CAFE? CAFE stands for C for there is heart abnormalities. What is the cardiac abnormality? Prolonged PR interval is going to be there. A for arthralgias, F for fever, and E for elevated ESR, which is going to be seen as a minor criteria. All right. No, it is not there in that, but there is a evidence of previous gas infection. So, evidence of previous gas infection is the ASO titers, okay? Or maybe there could have been a positive culture in the past. That is what I am saying. I am not including it over here. What is included here is the major and the minor criteria, which is Cafe Jones. All right, chalo ji. Then you have some suppurative and non-suppurative infections. What are the suppurative or non-suppurative diseases? What is the meaning of this? That my group A Streptococcus, which is the Streptococcus pyogenes, it can either lead to, so pyogenes itself means pus producing. So either it can lead to pus producing infections or it can lead to some complications which are not pus producing. So whenever it is going to cause me an acute infection, it is going to go inside the body and it is going to produce the pus. Okay? So it can produce that pus forming infections in the throat. It can produce that in any part of the body. All right. So if it produces in the throat, that is sore throat. It can also lead to scarlet fever. Okay. It can also lead to necrotizing fasciitis. So all of that means what? All of that simply means that there is pus producing infection. Then later on, because of this molecular mimicry, it is going to cause some complications. So first, a pus producing disease such as a sore throat. After 3 weeks or 3 months, there is a kidney failure, which has nothing to do with pus production. What does that have to do with? Antibody production. Okay. So of course, there is the suppurative infection and the non-suppurative infections. So suppurative can be because of pyogenic organisms, there can be abscesses, cellulitis, pus formation, and there is direct tissue invasion and pus formation. But in the non-suppurative, it is because of the autoimmune. So it could be acute rheumatic fever, it could be post-streptococcal glomerulonephritis, it could be rheumatic heart disease. This is because of the autoimmune reactions. Okay, there's another one which is called as the PANDAS, which is a pediatric autoimmune neurological disorder associated with group A streptococcus. Okay, that can also happen. So क्या features आप ऐसे लिखोगे? Like I said, always make a flow chart, always make a differences table. That is why everything up till now that I am showing you, it's either in the form of a flow chart or in the form of a differences table. So you will talk about acute infective endocarditis, subacute. This I have told you already. This is just a repetition. So the key points are infection plus endocardium is infective endocarditis. Always take multiple blood cultures. Think of the HACCP groups in culture, negative infective endocarditis. ARF is the autoimmune sequel of the gas infections, and the Jones criteria helps in diagnosis. Gas is beta hemolytic and Lansfield group A. Whenever you make this small little summary table in the end, the examiner gets super impressed. Why? Because everything when you have given in a little summary, even if they don't have time to read through all of it, they will read the summary and then they will realize that you know what you have written. Okay, always going to fetch you good marks. Okay, done and done, right? So infective endocarditis we have seen. Okay, this we have seen already. This is just a summary. This is the summary that you can make at the end of your answer sheet. This is the summary that you can make. You will say first pathogenesis, blood culture, culture negativity, ARF, Jones criteria and treatment. This is simple summary. Predisposing factor, valve injury, colonization, vegetation, metastasis. Done and done. 2 sets of blood culture, 12 hour apart, or 3 sets 1 hour apart, and at least 1 positive. This in fact is one of the major criteria. Culture negative infective endocarditis, think of HACCP. Over there you can do the serology or the PCR, because of course you cannot grow them. ARF can happen because of the autoimmune molecular mimicry. To diagnose, we have 2 major or 1 minor, 2 major or 1 major and 2 minor criteria. Treatment is of course empirical therapy based on the organism. So of course if it is GPC, it is different. If it is strep, it is penicillins. If it is GNBs, then it is the cephalosporins. Amongst the group A beta hemolytic streptococci, which is the gas, it is of course beta hemolytic. Then you can draw that small little diagram of a blood agar and then show them that this is the colony of streptococcus, and then show them that there is the clear white zone around it of the beta hemolysis. Okay? Strep pyogenes, it causes suppurative and non-suppurative. Then as we classified, alpha and viridins is alpha hemolytic and they are facultative anaerobes. We have known this. Group A is beta hemolytic and alpha is enterococcus, which we are not talking about today. Beta hemolysis is very important because there are 2 types of beta hemolysins, streptolysin O and streptolysin S. This streptolysin O is the one against which antibodies are forming. That is why I was talking about anti-streptolysin O or the ASO titers, right? So what is streptolysin O? It is one of the beta hemolysins. So since group A streptococcus is showing beta hemolysis, so it must be producing the beta hemolysin toxin. Okay. So against this beta hemolysin, which is streptolysin O, there are the anti-streptolysin O antibodies made, which is what is called as the ASO titers. Okay. Now what is streptolysin O? O stands for oxygen labile. It is also heat labile and it is highly antigenic. That is the reason that these antibodies are being produced, and that is the reason that I am detecting these antibodies to ensure a past infection with the organism. Okay? So of course S is going to be serum soluble, oxygen stable, but not antigenic and also heat stable. Alright? Done and done. Now we come on to FUO. What is FUO? It is fever of unknown origin. What is the criteria to make fever of unknown origin? What is the criteria to call any infection, any fever as of unknown origin is that we are not able to prove it. So there is high grade fever, always high grade fever. So the temperature has to be above 101 degrees Fahrenheit for more than 3 weeks, and there is no immunocompromised state, because if there is immunocompromised state, then you have explained the cause of fever. Okay, so there is no immunocompromised state, and all advanced clinical, laboratory and radiological investigations have come out to be normal. This is the exact definition of FUO. So patient walks into your clinic, says, I have been having high grade fever for the past 3 weeks. मैंने सारी जांच करा ली, I've gotten all the investigations done. Everything comes out to be negative. That becomes FUO. What are the causes of FUO? To everybody's surprise, actual infections are the attribute to 36%. They are the most common cause. So where are we lacking? We're lacking in ordering the correct investigations at the correct time to catch these diseases, because 36% are caused by infections, and in the world of PCR, if we are not able to catch an infection, then there is something really wrong in the way we are diagnosing. All right, so 36% is still infections. Around 26% is miscellaneous, we really don't know. Then the non-infectious such as SLE is 20%, followed by neoplasms at 18%. So you can simply make this pie chart and you can show that the major chunk, 36%, is because of infections, in fact. Okay. Examples include tuberculosis, which is the most common cause of FUO in the country. Enteric fever, which is caused by typhoid, because people tend to ignore the Basu rule. So they don't get blood cultures done, and in the first week, there is no antibodies produced. Brucellosis, because the culture takes a lot of time, 21 days. We are going to read brucellosis today as well. Endocarditis, because nobody cares about trying to figure out the Jones criteria. Malaria, because the peripheral smear usually it gets missed, and also in malaria the sample needs to be sent at every spike of fever. So if you will miss sending the sample at every spike of fever, then the parasite load is going to be very, very less. That is why it is not going to be visible under the slide and it will be missed. Abscess, there is some abscess in the body which is leading to fever, but we are not paying attention to it. Viral infections and fungal infections, because these are difficult to diagnose infections, they need special diagnostic modalities. Not every lab offers them. Okay, so TB, typhoid, brucellosis, endocarditis, malaria, abscess, viral infections, as well as fungal infections. That is what is important causes of fever of unknown origin. Sample collection karenge, what will we take? Blood. Absolutely everything. Okay, if we are not been able to diagnose, of course we cannot be picky and choosy about the test that we do. So we will take the blood, we will take the urine, we will take the CSF, we will take sputum, serum, biopsy, bone marrow, absolutely every sample under the sun. And as per the suspected cause, we can take it. Blood culture has to be done both aerobic and anaerobic. Urine cultures, bone marrow cultures, tissue cultures, everything needs to be cultured. Bacteria, virus, fungi and mycobacteria specifically we will mention for all. Serology is very easy. We will do MAT, SAT, CAT, ELISAs and molecular. So what is MAT, SAT, CAT? You know the mnemonic. Cat sat on a mat with my brother Lee. Okay, cat sat on a mat with my brother Lee. So cat is cold agglutination test, which is shown by Mycoplasma. SAT is slide agglutination test, which is shown by Brucella. MAT is microscopic agglutination test, which is shown by Leptospira. Yes, stool also. So today we are going to deal with these two, Leptospira and Brucellosis. We are going to read today, in fact, as well. What about ELISAs? All the infections you can think, you could get ELISAs, and PCRs and NATs for all. So you have certain molecular modalities such as BioFire, etc., which take care of all the important pathogens, and the it's a multiplex PCR. So many organisms can be caught with this PCR. Done and done. Then you have the next important topic, which is the infectious causes of anemia. Now, anemia can also be because of certain infections. So, you have iron deficiency anemia, you have megaloblastic anemia, and I've always told you, the moment you hear megaloblastic anemia or vitamin B12 deficiency anemia, please think of one name, which is the fish tapeworm, Diphyllobothrium latum. That is why this image has also been made. You know, the intestine has been made to look like a big tapeworm, right? Then there is hemolytic anemias, aplastic anemias and viral causes of anemias. Whenever there is iron deficiency, there is because of chronic blood loss or poor absorption. Who will cause chronic blood loss? The ones which lead to dysentery. So Trichuris trichiura, which is the whipworm. So we always tell the students a whipworm will it's not true fact, but it's just a way to remember. A whipworm will hit the intestine with a whip and there will be blood all around. So that is why whipworm or Trichuris trichiura is leading to bleeding or dysentery. Then schistosoma, which is called as the blood fluke itself. Then you have the hookworms and the hemoflagellates, okay, which can lead to iron deficiency anemia. Megaloblastic, of course, B12, because this huge giant tapeworm competes for nutrition in your intestine. So it does not, because vitamin B12 is only and only absorbed from food. This giant fish tapeworm, it's a very, very big, it's the biggest parasite infecting humans. Not just the biggest tapeworm, it's huge and broad that competes for nutrition with your body. So your body is not able to absorb all the nutrition, therefore there is B12 deficiency anemia. Hemolytic is because of destruction of RBCs. So of course there are certain bacteria and parasites and viruses which make RBCs their home. So if they are going to sit inside the RBCs, they are going to lead to destruction of the RBCs. Example, malaria. You know malaria or Plasmodium species, all those ring stages, trophozoite stages, all of that, where do you see? You see it inside the RBC only. So that is why it is going to lead to hemolytic anemia. Okay. So there is Bartonella hensleyi, Babesia, Clostridium, Epstein-Barr virus, hepatitis A virus and malaria. Must remember is malaria, Bartonella and Babesia. Okay, malaria, Bartonella and Babesia. Then aplastic, where there is bone marrow failure. Yes, viruses can be all H viruses. HIV, herpes simplex, EBV, which is human herpes virus 4 itself, varicella zoster, which is the chicken pox causing virus, that also is human herpes virus 3. Then you have hepatitis C virus, then then you have parvovirus B19. So all viruses with the name H and the parvovirus. Why? Because parvovirus binds to the P blood group antigen on the RBCs. So P for the P antigen. So all the H viruses and the P antigen. These are all important causes. So remember, iron deficiency anemia by the agents which cause dysentery and blood loss. Megaloblastic by Diphyllobothrium latum. Hemolytic by malaria, Babesia, Bartonella. Aplastic anemia and viral because of the all H viruses and the parvovirus B19. Alright guys, so that finishes so many topics. Quickly revise so many topics. Please go through the video once again and please try to incorporate everything in your head right before the exam. Now we have the HIV virus, the human immunodeficiency virus, HIV. Okay, the virus itself is leading to immunodeficiency inside the humans. Okay, it is because it goes and lives inside your own immune cells. Which immune cells? The immune cells which have CD4 receptors on their surface. Who are those? It is the T cells and the macrophages. So human immunodeficiency virus is going to go and lower your cell mediated immunity, because going and directly sitting inside the T cells and macrophages, because the receptor of HIV virus binds with the receptor of the T cells. What is the receptor of HIV virus? GP120. What is the receptor of T cells? CD4. Okay. So this is the most important thing that you need to know about HIV. This I have told you right now, even before beginning. So what are HIV viruses? They belong to the Retroviridae family. Why are they retro? Because in their multiplication, they go back one step. We all know the central dogma of life, that from DNA, there is RNA, RNA translates into protein, and that is what happens. But these viruses are RNA viruses, but they want to go and integrate inside the DNA of the host. Okay, inside the person's cell there is the DNA. What does HIV virus want to do? It wants to integrate itself with my DNA and live forever and ever with my DNA. Okay, so my body will never stop multiplying the cells. The virus DNA will also never stop multiplying because it has incorporated itself in my DNA. So for that, it has to first become a DNA. That is why the retro step. From an RNA, there is first a DNA forming. That is opposite. That is why it is retro. They are the retroviruses. They belong to the lentivirus family, which includes HIV, 1 and 2. A close cousin of HIV is HTLV1, which is a cancer-causing virus, which is an oncogenic virus. But we are not discussing that. What are we discussing? We're discussing HIV. So HIV was discovered in New York. In India, the first case was in 1986 in a sex worker. Okay. NACO is the National AIDS Control Organization. The algorithm given by it, we are going to see. The most risk of transmission is always through the bloodstream or through the blood transfusion, followed by the sexual route. However, in the sexual route, the most common mode is the sexual route. Okay, so the most risk is with blood transfusion followed by sexual route, but the most common mode in the whole world is the sexual route. Of course, it makes sense. Compared to how many blood transfusions are happening in the world, sexual activity is happening far more. Okay, so the most common risk will be sexual, but the maximum risk will be blood transfusion. Why? Because you're taking a big volume of blood and directly putting it into someone else's body. So you're taking a lot of virus and putting it in someone's body. That is why maximum risk is with blood transfusion. However, most common mode is sexual mode of transmission. Okay, so we have to make the structure of the virus and we also have to make the genome of the virus. I always try to make the structures for you just to remove that phobia and that pain from your mind. So many viruses, so many structures. There's just 4 things in the structure of a virus. And if you know the right mnemonics, like my students of Nishchay batch know, if you know the correct way to remember, there's no virus which becomes difficult. With just a 1 page of understanding, you can make the diagram of absolutely any virus they ask. But today I'm going to only tell you about HIV. It is very, very simple. So like I said, it's a single-stranded RNA virus. Now, all viruses have one common rule, that they are either RNA or DNA. They never have both. And they always have only one copy of this genomic material. So every virus on this earth which infects the humans, it will either have a single copy of a single-stranded RNA or a single copy of a double-stranded RNA, or single copy of double-stranded RNA and single-stranded DNA is also possible. But we're not going into that today. Basically, whatever is the genome, RNA or DNA, they always have a single copy. But HIV virus breaks that rule. Okay, it says, I will keep 2. What will you do? Nothing. We can't do anything about this virus. We have to agree to everything the virus says. So virus says that I will keep 2 copies of a single-stranded RNA in my genome. The mnemonic for enveloped viruses is PAP, and for the DNA viruses is PAP. So it is Papovaviridi, Parvovirus and Adenovirus. Amongst the RNA viruses, the non-enveloped viruses includes ones which was cancelled. So the Calciviridae family, which includes Hep E. Then there is the Rotahua virus, the rotavirus, and then there is the a family which has RNA in its name, the Picornaviridae family, which includes hepatitis A. This was all these hepatitis E and A families were also discussed in the hepatobiliary tract lecture which I took yesterday. So these are non-enveloped viruses. Except these 6, all viruses are enveloped. Okay, so you don't need mnemonic for enveloped. You just need mnemonic for non-enveloped. Rest all become enveloped. Okay, chalo. So like I said, it has 2 copies of a single-stranded RNA. So on top of this RNA, of course, there is going to be a nucleocapsid. So here is the capsid of this virus. Of course, outside the capsid, there is going to be a envelope. In between this, there will be some amorphous material which fills it up. What is this amorphous material? This is always the matrix. This is what is simple. This is the simplest way you can draw absolutely any virus. On top of this envelope, of course, there are going to be the glycoproteins or the peplomers, which are the little rhinestones on top of a virus. Yes, this is the common rule. Now, this HIV virus also has certain important enzymes on its RNA. So, I am going to draw 3 set of enzymes. Okay, so these are the 3 set of enzymes which are present on the RNA. So, this is the simplest way in which you can draw the diagram of HIV virus. Let's do one thing. Let's change the color of these, only this. Chal. Ban gaya? Ban gaya. Now we can easily label it. Yes? We can easily label it. Let's label it. सबसे अंदर क्या है? सबसे अंदर there are the 2 copies of single-stranded RNA. 2 copies of single-stranded RNA. So you will highlight 2 copies and single-stranded RNA. AC क्यों बंद कर रहे हो? Right? Then there are these 3 enzymes together. There are these 3 enzymes. Now, what is beautiful about these enzymes? So, you know, it's not a nice mnemonic, but it's a mnemonic which helps us remember things. Whenever somebody gets HIV infection, what will you say to them? If somebody gets HIV infection, there is just one thing left to do in life. That is rest in peace. Okay, RIP. So that is the enzymes that it produces too. What are the enzymes produced by it? RIP. The rest in peace enzymes. What is R? It stands for reverse transcriptase. Reverse transcriptase. Of course, it needs the reverse transcriptase enzyme to do reverse transcription, to change its RNA to DNA so that it can integrate with the human being. I stands for integrase. Integrase. Like I said, the DNA of the virus has to integrate with my DNA. So for that, it needs the integrase enzyme. Good evening, Brijesh. And then P stands for protease. This protease is needed to make all the genes necessary to make the structure of the virus. Okay? So it is the RIP enzymes. Then outside that, this is the capsid. The blue one is the capsid. The capsid is coded for by the P24 antigen or the P24 gene. Okay? This is important to remember. That is, I have written it separately. What is this? What is this? This is the matrix. The matrix. Then outside the matrix, of course, there is the envelope. Outside the matrix, the outermost portion is the envelope. Okay, envelope. So let's label the envelope over here. Now, what are these proteins which are present on the surface of the envelope? This blue one is the GP120, the glycopeptide 120, and this orange one is the GP41, the glycopeptide 41. These are envelope proteins. What are they? They are both of these are your envelope proteins. Proteins present on the envelope. Envelope proteins. Okay. Done and done. Now we have to look at the genome, right? So since it's a single-stranded RNA, we will always make a single strip or a single line for a single-stranded RNA. ठीक है? क्या होगा इस single-stranded RNA में? There is going to be all the genes which are going to make all of these important structures, right? So of course, in the genome, when you will draw the genome, you will say that there are some important structural genes. 3 important structural genes are there. GAG, POL and ENV. And then there are some non-structural genes such as TAT, REV and NEF. Okay. So these are your non-structural genes. Non-structural. They're not going to code for anything which makes up the structure. And these 3 are your structural genes. So what structures have to be made? All of these. The enzymes, the nucleocapsid, the matrix, the envelope proteins. All of this needs to be made. So we have the ENV gene which is going to code for the envelope proteins, right? The envelope protein. So the ENV gene will code for GP120 and GP41. Yes, which these two. So these two are going to be coded by the ENV gene because it's the envelope proteins. Then what are these? This is a pool of enzymes. This is a pool of enzymes. So it will be coded for by the POL gene. So the POL gene will code for the pool of enzymes. So you have reverse transcriptase, integrase and protease, the RIP enzymes. Okay. Then what is remaining is the nucleocapsid, which is the matrix as well as the capsid. This is coded for by the GAG gene. So GAG gene codes for the matrix and the capsid. Capsid is the main antigen, which is the P24 antigen. Okay. So what are the main antigens? It is GP120, GP41 and GP, and your capsid, which is the P24. So these are the antigens simply that we are going to use in the lab diagnosis. So you know that the mainstay of lab diagnosis against HIV virus is to detect antibodies. So which antibodies will I detect? Anti-GP120, anti-GP41 and anti-P24. And to make it advanced and to overcome the window period, I will also detect the P24 antigen. Why do we read the structure? Why do we read the genes? So that we can easily write lab diagnosis. Anything that is important in the structure, anything that is important in the pathogenesis, that itself is always the most important in the lab diagnosis. People say, ma'am, I'm not able to remember the lab diagnosis because you're not connecting the dots. Never in the lab diagnosis will you find anything new. It is always the virulence factors, it is always the structure. That is what we are trying to detect with lab diagnosis. No matter what fancy names we give it, it is always the same recipe, it is always the same story. Whatever is important in the structure, whatever is important in the pathogenesis, that itself is going to be detected in the lab diagnosis. So here with these genes and with this structure, I have realized that only these three important proteins that I have read, GP120, GP41 and P24, these are the only ones that I am going to detect in the lab diagnosis as well. All right, done and done. So you please draw this. Then when I say HIV, it is further divided into the two serotypes, which is the HIV 1 and 2, depending upon the nature of the GP120, which is the outermost protein on the surface. Okay? HIV 1 and 2. 2 is not there in India. It is limited to Western Africa. So in India, you will only and only find HIV 1. Amongst that, in India, it is the C subtype, which is the most common. Okay, C subtype is the most common. Then you have a term which is called as quasi-species. What is quasi-species? It means that a single person gets infected at the same time by two serotypes of HIV at the same time. Okay, now when these subtypes, they infect at the same time, they can also mix up. And when they mix up, they become a recombinant form. And this recombinant form can circulate in the environment. That is why they are called as circulating recombinant forms or CRFs. Okay. So these are two terms which students confuse. So of course, the HIV virus has two major groups, subgroups and further serotypes. Okay. Whenever a single person gets infected with two serotypes, that is called as quasi-species, and inside that same person these two serotypes can recombine and make a recombinant form. Now this person is infecting other people with this recombinant form. So now this new recombinant subtype is circulating in the environment. So I call that circulating recombinant form. Okay? So remember the two important words, quasi-species and circulating recombinant form or CRF. Now you have to write the pathogenicity or the life cycle. The first step in the life cycle of any virus is binding or attachment. Okay. So I always tell the students the love story between a virus and a human cell. Yes, a virus will always only live inside a human cell. So how does the love story happen? First of all, there is attraction and attachment. What is that? Binding. The virus will come and attach to the human cell. Once it is attached, they fall in love. And when you fall in love, you melt in love. So when you melt in love, you fuse with each other. Okay. So now the virus will fuse with the cell membrane. Once it is inside the human cell, it will take off its coat, that is called as uncoating. That is, the virus will remove the nucleocapsid and the virus ka genome, DNA or RNA will come outside. Now this DNA and RNA will integrate with the human cell DNA and RNA and they will live happily forever and after. Now the virus will live happily with the human DNA, but the human will never live happily ever after. Okay, so this is the love story between HIV virus and the human cell, and that is the saddest story for any human being ever. So you simply have to produce this love story onto your answer sheet and you will be good to go. So first of all, there is the attachment. Which are the most important attachment factors? So, Sohar, we are going to bring in a bridge course anyway. So, please watch FARRE series at the end of your first year, okay? So, in the first year, you should think about building your basics. So, we are going to have the bridge course. You can include that. We are going to have the survival guide. You can watch that. then you start with the normal lectures of first year. Take your time, don't jump to the exams. In the end, you watch the FARRE series. Okay, FARRE can never be a bridge course. All right, chalo. So what was I saying? Attachment. First of all, there is attachment. Attachment ke liye, which is the main antigen, this one, the outermost antigen. Which was the outermost antigen? It was GP120, which will cause the binding. Okay? After binding, the virus is going to fuse with the host cell. And who is going to fuse? GP41, which is the fusion protein. Now, this binding, good evening, Jeet, nice to see you. This binding is always incomplete with just these two proteins. So imagine, and who do they bind to? They always bind to the CD4 cells of my body. Okay, CD4 cells. So suppose it is a T cell which has the CD4 receptor. Okay, I am the HIV virus. My head is the GP120 antigen and my body is the GP41. So this GP120 is going to combine with the CD4. Okay, now this binding is not stable. Any moment I can slip off from this. Yes. So in order to stabilize this binding, I need to catch hold of the virus using my hands. What are the hands? These hands are the ones holding on to the receptors. What are these hands holding on to? They're holding on to the CCR5 or the CXCR4 receptors. These are called as co-receptors. Now always please remember that the main antigen binding is not more or less important than the co-receptor binding. Matlab, co-receptor binding is always as important and as crucial as the GP120 or the main binding. Okay, always most important, because if I don't hold on with my hands, I will slip away. So while this GP120 binding is very important, the holding with the hands is also super important. What is the holding with the hands? The CCR5 and the CXCR4. My students like to remember it as chai cigarette 5 rupees. Yes, chai cigarette rupees 5. That is CCR5. No, you cannot watch it for NEET UG Prep Upadhyay. Sid, please go and watch the lectures intended for NEET UG preparation. All right, chalo. This is MBBS second year, my dear. Chaliye, co-receptor is CCR5 and CXCR4. How important are they? That can be shown by the mutation. They are so important that the people who have any mutation in the CCR5, such as the delta 32 mutants, the delta 32 CCR5 mutants, they become totally resistant to the virus. They are protected from HIV. That is how important this co-receptor binding is. So people who don't have, oh, nice to meet you, Dr. Monin Hindi. Okay, I don't know what your name is, but oh, is it Doraemon? Doraemon in Hindi? Okay, nice to meet you, Doraemon. Anyways, so what was I saying? That it is so, this co-receptor binding is so important. Yes, correct. In the Scandinavian population, this delta 32 CCR5 mutation is seen. So it is so important for binding that they have CD4 inside their cells. The virus has GP120. What do they don't have? There is a mutation in the CCR5, and that totally does not allow the virus to bind. So they are totally protected. Yes, this is not virology. This is bloodstream infections, Doraemon. We have come on to HIV. ठीक है, चलो जी. So binding is complete. So what will you write? Binding happens with GP120 along with the co-receptor CCR5 and CXCR4. CCR5, chai cigarette 5 rupees. Yes. After that, the virus will bind, will fuse, and it will fuse with the GP41 protein. Yes, it will fuse with the GP41. Once it has fused, it will go inside the cell. It will remove its coat. The RNA of the virus will come out. That will cause reverse transcription. The reverse transcriptase will get activated, and the endonucleases, which are the scissors, they remove the RNA strand. RNA dependent DNA polymerase, which acts like a glue, it polymerizes the DNA. Then the double stranded DNA becomes circular DNA, and with the help of integrase enzyme, it integrates into the host DNA. This is the reason for clinical latency. That is why for the longest time, for up to 10 years after HIV infection, the person does not produce any kind of symptoms. All right. It's good. It's good if you read it. A positive sense single-stranded RNA is simply an RNA which has the genomes exactly like mRNA, okay? So they themselves can act like messenger RNAs or mRNAs. That is what is a positive sense. So now that the integration inside the human cell is complete, now the virus is going to sit there nicely. It will stay hidden. No symptoms are getting produced. That is why for many, many years after infection, the person tends to catch the infection after many, many years because of this clinical, mind you, clinical latency. There is no sign and symptoms, all right? So disease progression can be, there are some typical progressors in which the disease or the sign and symptoms come after 10 years of infection. Then there are some rapid progressors which are poor people, bichara, in them the clinical symptoms start coming within 2 to 3 years. And there are some long-term non-progressors. See, this is not important right now because this is something that they're not going to ask. The main difference is going to be that has to first convert into mRNA and then cause the translation. Over here, this itself can cause. So that makes it, provides a faster multiplication to the virus. Even though this is not relevant to the topic we are discussing, there I have answered you. Please, let's focus on the HIV and virus that we are discussing because we have to complete the entire bloodstream infections. All right. Cut, chalo. So this is a question meant for first year बायोकेमिस्ट्री एंड नीट यूजी प्रॉबेबली. चलते हैं आगे. लॉन्ग टर्म नॉन प्रोग्रेसर्स कौन है? दीज आर द पीपल who are able to control multiplication for up to 20 years. Okay, they are the ones in which the disease will take almost 20 years. In them there is not going to be any disease for such a long time. And then there are some elite controllers, elite, who are totally different group of people. They will always keep the virus to such a low level that only less than 50 copies per ml are going to be produced in those people. Okay? So less than 50 copies. Even your PCR machines, they need at least 100 to 300 copies of a virus to detect them. In these people, the virus is not able to multiply a lot. They are able to control the virus up to less than 50 copies per ml. So you have typical progressors, rapid progressors, long-term non-progressors, and elite controllers. So you will get the information very, very soon. Please look out for any information that you can get from the company. चलिए, disease course क्या है? First of all, there is going to be the acute retroviral syndrome. ठीक है. Acute retroviral syndrome क्या होता है? It is like any prodromal symptom. There is going to be generalized lymphadenopathy. There is going to be fevers, unexplained fevers. Patient will not know why he's just having a low-grade fever and lymph node enlargement. Then there is going to be a stage of clinical latency. Why was this happening? When the virus DNA was integrating with the host DNA, then there was clinical latency. All right. Meaning that now the person will not have any sign and symptoms. This can last up to 10 years. This can last up to 20 to 30 years. Okay? Then we have persistent generalized lymphadenopathy. Okay? Persistent generalized lymphadenopathy. What does that mean? That there is lymphadenopathy and it is persistent and the person does not know why. Finally, the AIDS-related complex starts when the person starts showing oral thrush, unexplained diarrheas, all of that, which is a marker which always tells a doctor that, okay, you should think of AIDS in this patient. And finally, there is AIDS, which happens. What is AIDS? AIDS is not equal to HIV. So a person can be HIV positive, but they never go on to full-blown AIDS. But then there are some people who become HIV positive and then they go on to become full-blown AIDS patients. So like I said, acute retroviral infection, within 3 weeks of primary infection, there is flu-like syndrome. Then clinical latency, but not microbiological latency. This is important. Then asymptomatic stage comes, persistent lymphadenopathy, and finally AIDS-related complex. So what is AIDS? It is defined by CD count less than 200 and there is presence of the AIDS defining illnesses. What are AIDS defining illnesses? The illnesses which don't commonly infect normal people, but when they start producing full-blown diseases in HIV positive patients, we call them as AIDS defining. Meaning whenever in a person You find these diseases, that is your sign that the person has gone into full-blown AIDS now. ठीक है? Example, PCP, pneumocystis pneumonia, pneumocystis jirovecii pneumonia, tuberculosis, candidiasis, especially oral thrush and esophageal candidiasis, toxoplasma, cryptococcus, cytomegalovirus, chronic diarrhea because of cryptosporidium. Then non-Hodgkin's lymphoma and Kaposi sarcoma. Certain cancers also come, right? So what are these? These are all the major opportunistic infections which are happening in a person of HIV because their CD4 count has decreased very, very low, meaning that the T cells have been killed a lot and now they are succumbing to all of these simpleton microorganisms which can't cause infections in normal healthy people, but in these HIV positive people they can break havoc. Okay, they can cause a havoc. Chaliye. Now, lab diagnosis mein we have the 3C principle. First of all, most importantly, you have to take the consent of the person for testing. You have to maintain confidentiality. You cannot reveal the results to anybody and they have to undergo counseling. Patients has to undergo counseling. ठीक है? उसके बाद screening test करते हैं हम. What are screening tests? This is antibody detection. Simply, I am detecting the antibodies against the GP120 protein. I am detecting antibodies against GP41. GP120 and GP41 combined together are GP160. Okay? Finally, there is the anti-P24 antigen. So, where does this GP160 come from? You know, initially, there is a single structure containing both the components. This is called as GP160. Then that protease enzyme of HIV virus comes and it breaks it into two parts. What are these two parts? These are GP120 and GP41. So I can detect antibodies against this GP160. I can detect antibodies against GP120. I can detect antibodies against GP41. That is anti-GP120, anti-GP41 and anti-GP160. What is P24? P24 was the capsid antigen. So I can detect antibodies against the P24 antigen. Now you have 4 generations of ELISAs. First, second, third and fourth generation. Nowadays, what is preferred is always the 4th generation ELISA. Because in this, along with you detecting all these antibodies, we also detect the P24 antigen. This is the one which is in use, and what is the benefit of doing this? That we are able to overcome the window period. Okay, overcome the window period, because even in the window period, the P24 antigen is going to be detected, right? So what was the difference? In first generation, we were using whole virus. In second generation, we were using specific antigens. In third generation, we started using synthetic peptides. Finally, in the fourth generation, we are not just detecting antibodies, but we are also detecting the P24 antigen. Because always in primary viremia, there is P24 antigen present. So P24 antigenemia. Okay, and antibodies against the proteins, they last the longest. That is why we prefer to detect antibodies against these guys, because they last the longest always, and the window period, which is around 3 to 12 weeks, can be overcome by detecting the antigen. Followed me on the app. Oh, thank you so much, Nishanam. All right, that's very nice. I hope you continue the streak and you keep impressing your faculties up till your final exam as well. So good to know that. Good to know. Thank you for your compliments. Please keep studying. Please keep performing better. Let's hope for a distinction. All right. So the rapid test that we can do is TRI-DOT, comb test, and a card test. A card test is a simple immunochromatographic test or a simple ICT. Yes, so that will show me a control line and a test line, show me that the antibodies are present. What do I do in a TRI-DOT? This is immunodiffusion. So basically 3 dots get formed. On these, one is the control, one has antigens against HIV1, one has against HIV2. So whenever a person has antibodies, this is going to produce these 3 dots on the card. That is a tri-dot test. Similar modality done on a equipment which looks like this, like a comb, and it also produces these dots on the comb. That is called as the comb test, or there can be the dipstick test. So what are the rapid formats of detecting these antigens and antibodies? Tri-dot, comb test, and lateral flow assay, or the card test. Good evening, Prince. Then you have the confirmatory test. This is all screening. Simply for screening, we are detecting antibodies. What were the antibodies? Anti-GP 160, anti-GP 120, anti-GP 41. Plus, we were detecting the anti-P24, also the P24 antigen. Okay? Now, we can also do confirmation. Confirmation is done by Western blot. What does Western blot do? It is used to confirm a positive ELISA test. So basically, it is helping me detect all the important HIV proteins, all of them. GP 160, 120, 66, 55, 41, P24, P17, all the important ones can be detected using Western blot. So Western blot is always confirmatory. Then you have the nucleic acid tests. You have such as the PCR, in which you can detect the viral RNA. You can also detect viral DNA. This is done for infants, called as early infant diagnosis. What is it called as? Early infant diagnosis. And for that, we use the dry blood spot. We simply take the blood from the heel of an infant and we dry it on a cellulose paper and we send it to the lab. In the lab, they are going to perform a DNA PCR from this sample. So early transport and storage can happen. It is useful in infants, wherein we need to detect the PCR directly, because in an infant, antibodies will not be formed up till now. So we cannot wait for the 12 weeks for the antibodies to form. So in all the infants, in all the children less than 18 months of age, we want to detect the HIV virus early. So we can do the dried blood spot test, in which we are drying the blood on a cellulose paper and we are sending for DNA PCR. Okay, done and done. Some non-specific tests can also be done. So all of this that we were doing until now, we were doing specifically for HIV. We were detecting specific antibodies against HIV. We were detecting specific antigens of HIV. We were detecting specific proteins of HIV. Now we are, or the RNA DNA, now we are detecting not HIV virus, but we are looking at the effects of HIV virus. So what is the effect? It reduces the CD4 count, because it kills the T cells, it kills the macrophages, it kills the cell-mediated immunity cells. All of those cells have the CD4 receptors on them. So the overall CD4 T cell count in the body is going to reduce in HIV positive people. So, and now suppose you have started giving ART to the patient, or HART, highly active antiretroviral therapy, right? Now you want to see response to treatment. You want to see whether this treatment is working or not. One thing you can always do is you can detect the viral load. So at the beginning of the treatment, when the patient had come, suppose their viral load was very high. After starting the treatment, after 6 months, the viral load should reduce. The second thing you can do is you can check for the CD4 counts. Initially when the patient had come to you, their CD4 must have been very, very less. When you give the treatment to the patient, the CD4s, they start improving. So you will see a decreasing trend of viral load and an increasing trend of CD4 count, which will tell you that your patient is responding to the ART therapy. Or initially, to make a diagnosis, you can see that in this person the CD4 count is very, very low. When the CD4 count is very, very low, that should be your first thing to stick to your mind, that probably this person is HIV positive. All right, done and done. Now this is something that all the students are always scared of. What is this? This is the NACO algorithm for diagnosis. Now don't be scared of it. Very simply, we will read. You need not remember so much and you need not be able to draw all of it. What can you simply remember? That there are 4 important algorithms given by NACO which determine how you're going to diagnose a case. Okay. It basically tells you that how many kits of HIV should you use while testing. Should you only use a single kit? Should you use 2 kits? Should you use 3 kits? It all depends upon what are you trying to do. So you have the algorithm 1, algorithm 2A, algorithm 2B, and algorithm 3. It is not 1, 2, 3, 4. It is, yes, we all hate this diagram, but I'm going to simplify it for you. It is 1, 2A, 2B, and 3. Okay. 1 is only done for transfusion and transplantation safety. So whenever you donate the blood, that blood goes to the blood bank and first they test this blood for HIV virus. Okay. Many of you must have also donated and you get that SMS on your phone saying your testing is complete, or if it comes out to be positive, you're called to the blood bank for counseling. Okay. So whenever the blood bank receives a blood, they check it for HIV. That is algorithm 1. What are they supposed to do? They're only supposed to use one kit. Okay, so remember, algorithm 1 is one kit. If it is positive, it is positive. If it is negative, it is negative. Then what do? Kit 2 is done for surveillance. Surveillance. What is surveillance? You get patients admitted to your hospital for any reason. A pregnant woman supposed to undergo HIV testing. A person who simply has come for some other surgery, you do HIV testing. Person admitted for any other. So it's just a surveillance. Okay, just general. There are no sign and symptom. There is no suspicion. Person has come for anything else, surgery, pregnancy, but you are checking for HIV. That is algorithm 2. So that is screening for surveillance. You use 2 kits. How many kits do you use here? You use 1 or 2 kit. 1 or 2 kit. If it is negative, it's a simple 1 kit. Otherwise, you confirm using 2 kits. If it's a positive, then you listen to anything that the second kit says. The second kit says positive, you call it positive. The second kit says negative, you call it negative. You don't care now what the first kit has said. Okay. So, algorithm 1 was done on the collected blood in the blood bank. Okay, positive, positive, negative, negative, 1 kit. Algorithm 2A is done for surveillance. Okay, it is done using 1 or 2 kits. If it's negative, it's fine. If it's positive, then you do with another kit, and whatever the second kit says, you agree to it. Okay, if it calls it positive, it is positive. If it calls it negative, it is negative. That is algorithm 2A. What is 2B? 2B is done with AIDS indicator disease symptoms, meaning people who are showing signs and symptoms, who are showing the clinical features of AIDS, and now you want to detect AIDS in them. Okay, in them you will do 2 or 3 kits. So what is required here? 2 or 3 kits. So what was required here? 1 kit. What was required here? 2 kits. In 2B, you use 2 or 3 kits. Okay, a negative is always negative. Okay, first time negative is always negative. The thing changes whenever you have a first time positive. So here you have a first time positive. You go on to the second kit. If it is positive, you simply say positive, khatam baat. If now you have some confusion, plus and minus, now you go on to the third kit. That is why it is 2 or 3. It is not compulsorily 3. It is 2 or 3 because it can end at 2 also. Right? If 2 came positive, it will end here. You only go to the third whenever there is a confusion. So it is 2 or 3. Whenever there is a confusion, you go to the third one. Whenever you have 2 negatives, you call that as negative and you move on. Whenever you have 2 positives, then it is indeterminate and you need to now go for a PCR to check. Okay. So, one is what? One is done in the blood bank, 1 kit. 2A is done for surveillance on all people, like pregnant people, patient admitted for surgery. That is 2 kits. Whatever the second kit says, you agree to it. 2B is done for people showing symptoms of AIDS-related complex. There you use 2 or 3 kits. If 2 are positive, it is positive. If you have confusing results, then you go to the third. All right. Finally, you have 3. Algorithm 3. In algorithm 3, you compulsorily use 3 kits. So 1 kit, 2 kit, 2 or 3 kit, and 3 kit. Right? In this, if 1 comes positive, you go to 2. Irrespective of what 2 says, compulsorily you have to use a third kit. Here you could have not used the third kit also. You could have stopped at the second kit, but here you have to compulsorily use the third kit irrespective of what the second kit is saying. Okay, so if kit 1 says positive, you go to second. Now second can say or positive, it doesn't matter, negative, it doesn't matter. You go to third. In the third, whenever you have all positive, you call it positive. Okay, whenever you have anything else, it is indeterminate. Okay, in this anything else, if you have two negatives, usually whenever you get two negatives, you call that as negative. But here you will look at the risk. If the person is low risk, then you consider it negative. If the person is high risk, still you call it indeterminate. So a third kit is used for to detect HIV in asymptomatic individuals. Okay, so you cannot see the screen. Why can't you see the screen? All right. So, in the third kit, you do it on people you suspect should be having AIDS, but they are asymptomatic, or there was such a history suggestive in the past. This is like Uno rules, but you made it simple. All right. Thank you so much. Right. So, it is actually quite simple. It's just overwhelming to look at it. So, just remember, kit algorithm 1 is one kit. It is done on a blood bag, in the blood bank. Kit 2, algorithm 2A is two kits. It is done on surveillance, on surgery patients, pregnant patients, etc. And over here, whatever the second kit says, you believe it. Algorithm 2B is done on patients showing symptoms suggestive of AIDS. And here you use 2 or 3 kits. Whenever the second kit says 2 positives, you move ahead. If there is a confusion, then you go to the third kit. Okay. And algorithm 3, you have to compulsorily use the third kit. So the second can be positive or negative. Compulsorily use a third. All are positive, it's a positive, no doubt. Rest everything is a doubt. If two negative, you only call it negative if a person is low risk. But if a person has high risk behavior, it again goes to indeterminate. And always for indeterminate, you need to do a PCR. Finished. This is NACO algorithm. Now I hope you will wish that you are asked to make NACO algorithm in your exams, because now you can very, very easily draw it and make it. Okay. What I want you to do is I want you to write down and practice making this NACO algorithm so that it gets ingrained into your brain and you never have to confuse again. Okay? Done and done. We are done with it. Now, there is one important thing which is usually asked in the Vivas. That is iris. What is iris? It is immune reconstitution inflammatory syndrome. Immune reconstitution inflammatory syndrome. Iris, it occurs after initiation of ART. So, usually when you give ART to a patient, you think that the patient should start improving. But what happens paradoxically here is, you start the patient on ART and then the patient starts to worsen clinically, symptomatically. Person is improving at a molecular level. Virus is dying. But for that moment, clinically, the person starts to worsen. The symptoms of the person, they worsen. But the disease has not worsened, okay? It is due to recovering immune system of the person. Okay, mounting on the inflammatory response against the existing infections. So initially there was low immunity. You start the ART, there is a higher immunity, and now this restored immune cells, they start creating havoc in the body, trying to fight all of the opportunistic infections. That inflammatory response or immune response, that is the worsening of the symptoms. That is called as IRIS, immune reconstitution inflammatory syndrome. Very, very important. All right. So, we have finished very important viral disease, which is the HIV virus. Now, what do we talk about? We talk about the viral hemorrhagic fevers. Please understand, the name itself says that these are viral fevers and there is fever with hemorrhages. Hemorrhages can present as petechial rashes. Hemorrhages can present as bleeding from gums, as hemoptysis. So, basically, there is going to be fever with rash or any bleeding manifestation. Whenever you have a fever with rash, you always think of these viral hemorrhagic fevers. Can you tell me one bacterial hemorrhagic fever? Yes, it is Leptospira. Leptospira causes Weil's disease, which is hepatorenal hemorrhagic fever. Okay, so that is a bacterial hemorrhagic fever, but we are talking about VHF. Usually, you have your arthropod-borne or arboviruses, which is the arthropod-borne viruses which cause this. Amongst these arboviruses, you have certain groups. Then you have filoviruses, which are the filamentous viruses, and some rodent-borne example, the hantavirus. One common rule is that all of them are enveloped RNA viruses, and there is no specific treatment or vaccine for most of them. Okay, so now dengue vaccine has come up, but there is no antiviral for it. It is always supportive therapy. All of them are single-stranded RNA viruses. All of them have an envelope. Okay, what are the important families? You have the Togaviridae or the Togachoga, which is the chikungunya virus. Then amongst the Flaviviridae, you have this, and my students would know the very beautiful mnemonic for the Flaviviridae. See, the word flavi stands for yellow. The meaning of the word flavi is yellow, right? So we all imagine that there is a kid who's wearing a yellow vest and he's a DJ. So what is the mnemonic? Yellow vest kid is DJ. So yellow stands for yellow fever, vest is West Nile encephalitis, kid stands for KFD, A stands for Zika, D is dengue, and J is Japanese encephalitis. All of these belong to the Flaviviridae family, which can cause viral hemorrhagic fevers. फिर Bunyaviridae में there is Creman Congo hemorrhagic fever, also called as CCHF. And in the Rhabdoviridae, you have the Chandipura virus. Chandipura, you can remember that it belongs to Rhabdoviridae. Rhabdoviridae is the family which is bullet shaped, just like rabies virus. Okay, so just remember like a bunch of bullets which are made up of silver and they're scattered in the sand. So you can remember Chandipura transmitted by sand fly. Okay, so you have Togachoga viridae, chikungunya, Flaviviridae, yellow vest kiddies DJ, yellow fever, West Nile encephalitis, KFD, Zika, dengue, and Japanese encephalitis. Bunyaviridae including CCHF and Rhabdoviridae including the Chandipura virus. Okay, what are the vectors which are the arthropods which can cause these diseases? This is the mosquito, ticks, and sandfly. It is very easy to remember what are the infections caused by tick. Just write tick. When you write the word tick, you have a C and a K. So CCHF and KFD is what are caused by the tick. Okay. Then mosquito and Chandipura, I had told you, silver bullets in sand. So that easily you can remember that the silver bullets in sand is caused by the sandfly. Sandfly. Rest everything else is caused by the mosquito. And that too, Culex. Just remember Culex as Cutex. So it remembers cute. So who are cute? Japanese people are cute. So only Japanese encephalitis is caused by Culex. Rest all are caused by Aedes aegypti and albopictus. So these are rest all. So your life now becomes very, very easy. ठीक है ना? So when I say viral hemorrhagic fevers, and I say all of these viruses, it is either mosquito, tick or sandfly. Tick has the letters C and K, so it is CCHF and KFT. Sandfly is the silver bullets lying around in sand, so it is the sandfly, which is the Chandipura virus. Rest all is mosquito and only Japanese are cute, so Cutex or Culex is Japanese encephalitis. Rest all dengue, West Nile, Zika, they are all caused by the Aedes group of mosquitoes. Done and done. Okay? Easy to remember. What happens in dengue? It is hemorrhagic fever. There is arthralgias. There is retroorbital pain. Retroorbital pain. In chikungunya, there is severe arthralgia, but there is no hemorrhage. Okay, it does not lead to blood loss. KFD is also hemorrhagic fever. It can later include the brain causing encephalitis. Yellow fever is hepatorenal hepatitis. We have seen yellow fever yesterday in the hepatobiliary tract. Then you have Japanese encephalitis and West Nile encephalitis that has encephalitis in its name. CCHF is also a viral hemorrhagic fever and Chandipura is also a viral hemorrhagic fever or encephalitis in children. Okay. So we will see each one of them. Let's start with dengue virus. Dengue virus is single-stranded RNA icosahedral and enveloped because all of these viral hemorrhagic fever causing viruses are single-stranded RNA, icosahedral symmetry, envelope and proteins. All viruses have the same morphology. There are 4 important serotypes of the dengue virus. Then 1, 2, 3 and 4. Most important is Aedes aegypti. However, Aedes albopictus can also cause infection in the urban cycle. Right? There is an extrinsic incubation period of 8 to 10 days. What does that mean? Incubation period is the time between infection to arrival of the symptoms. So, intrinsic incubation period is that once the mosquito bites me, the virus is inside my body. Now, when I get a fever is usually 1 week after. This is intrinsic incubation period. Now, the virus has to go back into the mosquito. How long does the virus take to develop inside the mosquito so that it can be mature enough that when the mosquito bites, it is able to transfer the infection? That is extrinsic incubation period. It is not happening in the human body, it is happening in the mosquito body. It is around the same time, 8 to 10 days. So, in the mosquito also and in the human also, the incubation period is same. So, what is ADE? This pathogenesis is super important. There is a specific phenomenon associated with dengue virus called as antibody dependent enhancement. So, there is an enhancement of the disease or worsening of the disease because of the antibodies which are produced against the virus. That is antibody dependent enhancement. In simple terms, if I tell you in the simplest possible way, suppose you get dengue infection once in your life and suppose you got it with the DEN1 serotype. You had some fever, you had some platelets falling and then you improved and you were alive. Again, for the second time, you get a dengue infection. Now, if you were unlucky, this time you got it with the DEN2 serotype. Now, there is a guarantee that you will land up in ICU. This is antibody dependent enhancement because when you got infected with the primary infection for the first time with DEN1, 2 types of antibodies were made inside your body. One were the neutralizing antibodies, which are the killer antibodies. They were made and they went and that they killed the DEN1 dengue virus. Then there was another group which were simply the binders, the non-neutralizing antibodies. They don't kill, they simply stick to the virus. So there are 2 types of antibodies, the killers and the lovers. The lovers, they simply bind, they only stick, okay. The problem is that the killers are only serotype specific. So when you got infection with the DEN1 serotype of dengue, the killers are only able to kill the DEN1 serotype. The non-killer antibodies, they can bind to any serotype of dengue. Okay, but they can't kill, so they are useless. So the neutralizing antibodies, they kill the virus and the non-neutralizing antibodies are non-serotype specific. The non-neutralizing antibodies are now present in the body. You get a secondary infection with now a DEN2 serotype because you were unlucky. Now these non-neutralizing antibodies, they attach themselves to the DEN2 virus and then they totally cover this virus from all around. And you know that the FC portion of antibody, it calls these monocytes and these macrophages and these natural killer cells and they come and bind. Now there is a lot of cytokine production leading to vascular leakage, which leads to dengue hemorrhagic fever followed by dengue shock syndrome. So whenever you got the fever for the first time, you had simply gotten a dengue fever. Later on, after second attack with the second serotype, so the dengue fever you had gotten when you got a DEN1 infection, which was the primary infection. Then you got a second attack by the DEN2 serotype and now you're going to get dengue hemorrhagic fever or dengue shock syndrome. This is called as antibody dependent enhancement because the antibodies made in the first infection, they enhanced the cytokine production in the second infection. Please draw it in the form of a flow chart only. If you can draw a diagram, that is even more beautiful, but do not write it in the form of a sentence. Do not write it in the form of a paragraph. Your examiner is going to get bored. They will not care. You only make a flow chart of this, please, because it's a clear-cut concept. There are no confusions in it. And this is the most important thing that you have to write about dengue virus. If you don't write antibody-dependent enhancement in dengue virus, you're losing marks, okay? Chalo. Then you have the lab diagnosis of dengue. How do you do the lab diagnosis of dengue? You do antigen detection. So you have a non-structural gene, which is the NS1 antigen. You can do it by ELISAs, immunochromatography, RT-PCR. This is done usually on the day 0 to 5 of the fever. Okay, usually it is done on the day 0 to 5 of the fever. Then you can detect the IgM antibodies using ELISAs after the 5th day. You can isolate the virus in, of course, the mosquito cell lines, because it is a virus which is seen inside a mosquito. Then viral RNA by the PCR can also be done. So always before 5 days you detect antigen or the RNA. After 5 days you detect the IgM antibodies. Rapid test, so there is always a two testing mechanism. Whenever you do a rapid test, you can only give a probable report. You always have to then confirm it using an ELISA. So never label somebody as dengue positive based only on an immunochromatography or a rapid card test. You should always follow it up with a confirmatory test. All right. Then the test ELISA which is done for dengue is called as MAC ELISA. MAC ELISA. And if you make a diagram of it, it is even more beautiful. So my students would know that we have really simplified the MAC ELISA. So remember MAC ELISA as the double-decker Maharaja Mac. You know McDonald's Maharaja Mac, that is what is MAC ELISA. Always the upper bread and the lower bread or the buns of the burger, they are always going to be your antibodies. Then the center of the burger is going to have a patty and some lettuce along with it. So what are these? This is an antigen and an antibody complex. So the center is always made up of antigen antibody complex. This is what is a MAC ELISA, right? What is MAC ELISA called as? MAC ELISA is IgM antibody capture ELISA. IgM antibody capture ELISA is MAC ELISA. So what are you doing? You're capturing the IgM antibodies. So this is the well of a microtiter plate. What have I done? I have put some capture antibodies. Here is an antibody that I have totally covered the wells of the ELISA plate with. Okay. This I have covered all over the ELISA well. What is this? This is antibodies. This antibody is standing like this. It is waiting for the patient's antibody to come. So it is a capturing antibody. This is a capture antibody. So what is it? It is a, this here is a capture antibody, and the beautiful thing about this is that this is a anti-human antibody. Anti-human antibody. So this is an antibody formed against the antibodies of a human. Now I will take the serum of the patient. Patient serum is going to have antibodies against dengue virus. So those antibodies, especially the IgM type, are going to come and bind here. So what is this pink one? This pink one is the antibody which is the IgM type, which is in the patient's serum, which is there in the patient's serum. Okay. Now from my lab, I will add an antigen. So now I have added an antigen, which is dengue specific antigen, which will go and bind to this antibody, right? What can I do? I can make it specific. I can put some specific antigen. So this is Den 1, 2, 3 or 4, any serotype particular antigen I can put, and it will only that antigen will bind against which these antibodies have been formed in the patient. ठीक है? तो सबसे नीचे है capture antibodies, then there is the patient's IgM antibodies, then there is the red colored antigen which I have put from the lab. Okay, now I will put a secondary antibody here. What is this? This is a secondary antibody which is also anti-dengue antibody. This I have also put from the lab. What is this? This is the secondary anti-dengue antibody. Okay, this antibody I have conjugated with an enzyme substrate which is going to release the color. So this is a conjugated secondary antibody with the enzyme substrate conjugate. ठीक है, ये क्या है? This is the enzyme and substrate which is going to give me the fluorescence. This is your MAC ELISA. What had I said? Burgers are antibodies. नीचे भी there's an antibody at the bottom, there's an antibody at the top. These two are the burger buns. In the middle, there is an antigen-antibody complex. Yes, in the middle, there is an antigen-antibody complex. That is how you simplify a MAC ELISA for yourself. And if you draw this, you're getting beautiful marks. So please, please, please draw this, the principle of MAC ELISA, in your answers on dengue. So you will draw this IgM MAC ELISA, then you will write about dengue vaccines. Earlier, there was the yellow fever CYS chimeric tetravalent dengue vaccine, which was Dengvaxia. But now, very recently, just now, India has approved Qdenga, which has the DEN2 serotype as its backbone. All right, done and done. Done and done. What is chikungunya? Chikungunya is, chikungunya is called as a fever in which the person gets so much of pain that they are bent over like this. Yes, the person is bent over in pain. So when I am saying he's bent over like this, don't you think the person is kind of looking like this? Yes. What is this? This is the letter alpha. So chikungunya virus belongs to the alpha virus and the choga or the toga viridae family, right? It is a re-emerging disease because it was there in the 1950s and 70s, then it went away, and after 2005 it has really come up like anything because of the coming up of this vector, which is Aedes albopictus. Because Aedes albopictus came in the urban environment. So now this chikungunya has also started re-emerging as an important cause. In the urban cycle, the mosquito goes from human and mosquito. In the sylvatic or the forest cycle, it roams between monkeys and mosquitoes. It is milder than dengue. There is fever and arthralgia, meaning bone pain. However, there is no hemorrhages. Okay, there is a classical chick sign or the brownie nose sign in which the nose of the person becomes brownish. Okay, for lab diagnosis, you will do antigen and antibody, wherein the IgM antibody after 3 days becomes your mainstay of diagnosis. Just like dengue, this can also be isolated in mosquito cell lines, and you can also do the molecular, which is the PCR, in which you can detect the non-structural proteins 1 and 4. Okay, important to remember antibody detection. Then we have KFD, Cassonure forest disease. The Cassonure forest disease is found in India. It is found in the Shimoga district of Karnataka. Okay, it is and in the monkeys found in that forest are like the amplifier hosts. So my students would know, we always remember this monkey sitting with an amplifier singing in a forest. Okay, so remember Cassonure forest disease, there's a monkey singing on an amplifier. That is, the amplifier host is a monkey. The vector of it, however, is a tick, because we know when we write tick, it has C and K would stand for Cassonure forest disease or KFD. So that it is always the tick which is the vector. Usually people go to the forests for camping in the November month, so that is the seasonality. It causes high-grade fever and frontal headache. After 7 days, however, there is involvement of the brain leading to meningoencephalitis. And a formally inactivated vaccine has been made by the Hafkin Institute of Mumbai. So you can always include this also in your answer. Okay. Then the rodent-borne viruses, you have the important hantavirus, which was recently seen as an outbreak on a ship. Hantavirus belongs to the Bunia-viridae family. Bunia-viridae family, and it is rodent-borne. So who is the rodent? It is the long-tailed rats. It is the long-tailed rats. And from their long-tailed rats, there are the dried droppings. So it is secreted in these rats' feces, urine and saliva. and saliva. Okay. So what does it cause? It causes the hantavirus pulmonary syndrome or the hantavirus renal hemorrhagic fever. Okay. Hantavirus renal hemorrhagic fever. Two things. It can cause hemorrhages and renal failure. It can cause involvement of the lungs or the pulmonary disease. Okay. That are the two things caused by hantavirus. Diagnosis and only based on PCR only. Okay, PCR only. What is Bunia viridae family? My students would know that the B looks like 3. So it has a 3 segmented single stranded RNA genome, right? So even if you have to draw the diagram of hantavirus, the rule remains the same. 3 segmented single stranded RNA, icosahedral symmetry, envelope, proteins, over. That is the morphology of the hantavirus as well. हो गया ना, हो गया, डन एंड डन हो गया. चलो जी. नाउ वी हैव द फाइलोवायरसेस. फाइलो का मतलब होता है फिलामेंटस. सो यू हैव E bowl of noodles called as Ebola virus. So there is the Marburg and the Ebola virus. What is important about the two? That there is approximately 90% mortality or 90% death rate associated. So ऐसा virus जो मार देगा, a virus which is going to mar or kill is Marburg, and these are filamentous like a bowl of noodles. So it is the Ebola virus. Okay, Ebola virus. It is seen in Sudan and Congo. Recently, there was a extreme outbreak. WHO had warned that it can lead to pandemics, but it is more or less controlled. So there is the Zaire, Sudan, Bundi, Bugyo, and Thai forest strains. The Zaire is the most common strain, but the 2026 outbreak has happened because of the Bundi Bugyo strain. India is still protected against this. Okay, it happens because of close contact of chimpanzees, and in the humans the direct contact can happen from all the body fluids. All. So it can happen because of saliva, because of tears, because of respiratory secretions, because of urine, because of sweat. Absolutely any body fluid can transmit the virus between humans to humans. That is the problem. Okay, antigen can be detected, antibody can be detected, virus can be isolated, RT-PCR can be done, but it has to all happen inside a BSL-4 laboratory, because Ebola virus is a BSL category 4 agent, and you can simply draw the structure of a filamentous virus. Okay, done. So what are the key points? All viral hemorrhagic fevers are enveloped single-stranded RNA viruses. This holds true for all of them. There is no specific treatment, and arboviruses require a vector. So the vector can be ticks, can be sandfly, can be mosquitoes. And we know tick has C and K, so KFD and CCHF. Sandfly is the Chandi silver bullets lying in sand, so the Chandipura virus, and of course rest all is mosquitoes. Okay, general features are that there is sudden onset fever, there is myalgia, a headache, there is hemorrhagic manifestations, obviously leading to thrombocytopenia, vascular leakage, and multi-organ failure. These are the features of all viral hemorrhagic fevers. Okay, only supportive care is what is going to be your modality of treatment. One way to differentiate: dengue belong to flaviviridae, serotypes 1 to 4 caused by Aedes aegypti. Then it lead to plasma leakage, shock, arthralgias. NS1 and IgM is what we are going to detect. Chikungunya, toga viridae, Aedes albopictus, the chick sign, severe arthralgias, no hemorrhage, and IgM ELISA. Okay. KFD, Casanur forest disease, again flaviviridae caused by the ticks. Monkeys are the amplifier host. Monkeys are the amplifier, causes fever, headache, and meningoencephalitis. Of course, IgM ELISA and the formal inactivated vaccine by the Haffkine Institute, Mumbai. Yellow fever, again flaviviridae, Aedes aegypti, but it causes jaundice and hepatitis. Hepatitis. This we have discussed yesterday, and the 17D live attenuated vaccine is given. Crimean Congo hemorrhagic fever is also Bunia viridae. This is also by the ticks. Ebola, phyllo, filamentous, direct contact of humans. Multi-organ failure, very bad disease. RT-PCR is the only thing. There are no vaccines, no treatment. Then Chandipura is through rodents and through the sandfly. Done and done. Okay. So you can make this table also in your exams. We are done with very important viruses. We are done with infective endocarditis. Now, the only thing which remains is certain important bacteria. So, you have this, the brucellosis. What is brucellosis? It is a typhoid-like illness, but it is only less severe. So, there is the undulating fever, hepatosplenomegaly, and bone pains. Undulating fever means fever comes and goes, okay, and there is profuse sweating associated. So, Brucella malitensis is the most important. It is found in the cows. It is zoonotic. So, whenever you have history of ingesting unpasteurized milk or any vets or laboratory workers coming in contact, they can get the disease. Right, it causes Malta fever or the Mediterranean fever. You have to collect the blood which has to go in the biphasic medium, which is called as the Castaneda's medium. Castaneda's medium, okay. It takes 21 days to grow in the blood culture, 21 days. Therefore, it becomes important cause of fever of unknown origin. In the beginning of the lecture only we have seen. Good evening, Amal. So, it's a gram-negative cocobacilli, and we can do serology and molecular PCR. Serology is very important, which is the SAT. Cat sat on a mat with my brother Lee. So, SAT was Bru. So, that was Brucella. What is SAT? It is just like Vidal test. You do serial dilutions and you detect the antibodies in the patient. A titer of more than 1:60 is what is important. Then there is something which is called as 2-mercaptoethanol SAT. 2-mercaptoethanol SAT. In which this, what do? We add 2-mercaptoethanol. What does it do? It destroys IgM. So, whenever I am doing SAT, I am detecting IgG and IgM both in my patient. Okay. But 2-mercaptoethanol kills IgM. So, if after adding 2-mercaptoethanol, still the SAT is coming positive, that means only IgG antibodies are giving the reaction. That means past infection is there. So, if SAT is positive, 2-mercaptoethanol is negative, that means patient only had IgM which were destroyed, therefore it is coming negative. So, the patient has recent infection. If both are coming positive, that means IgG was present and it is a past infection. If all are negative, it is negative. If there is any confusion, there can be the prozone phenomenon. Then we can do ELISAs. Inside the animals to detect it, we do a milk ring test or rose Bengal card. What is milk ring? In a test tube, we take a milk and there is a pink colored ring which is formed in that test tube. Okay. Before we come on to the spirochetes, this is one flashcard which will help me remember each and everything about brucellosis. So, this is caused by Brucella malitensis. Brucella malitensis. Yes, it causes Malta fever, also called as undulating fever. Undulating fever. What is the triad? Undulating fever, hepatosplenomegaly, and number 3 is the arthralgias. It is of course spread by cows. So, it is spread by ingestion of unpasteurized milk. And what will you do for testing? For testing, the mainstay is the standard agglutination test. In the animals, you can test by using the milk ring test, or with the pink ring you can remember the rose Bengal card test. Rose Bengal card test. This is the BSL category 3 agent, and you do the very famous biphasic culture medium which is called as the Castaneda's medium, which is used for this bacteria. Castaneda's medium. In this you do the blood culture. And blood culture takes around 21 days, and in 21 days you will grow what? Gram-negative cocobacilli. This is brucellosis, the one short flashcard for brucellosis. All right, done and done. Then what are these spirochetes? Spirochetes are these spiral bacteria. In this you have Treponema, which causes syphilis, which is totally separate, and you have the Leptospira and Borrelia. So, Leptospira causes leptospirosis. Leptospirosis is the R and R. It spreads in the rainy season through the rice fields and by the rat urine. Okay? So, on the dark ground microscopy, you will see the the spiral bacteria which is there. The spiral bacteria. Important strain is the Leptospira andamana strain. That is why it is also called as the Andaman hemorrhagic fever. The disease can happen in two phases, the septicemic phase and the immune phase. Yes, boring triplets, correct Amal, right? In the septicemic phase, there is vascular damage and damage to the brain. However, in the immune phase, the antigen and antibody complexes, they deposit in various places. Just to make your life very, very easy, it can be revised with this little flashcard. What is this flashcard? This is telling me everything about leptospirosis. So you can see the 3 R's, which is the rat urine, the rainfall of floods, and the rice fields. What is it causing? It is causing conjunctival suffusion. Conjunctival suffusion, which is seen where? It is seen in the common leptospirosis or the mild non-icteric leptospirosis. And then you have the Weil's disease. What is there in Weil's disease? There is fever, there is hepatic failure and renal failure. What is the Weil's disease called as? Weil's disease is called as hepatorenal hemorrhagic fever. Hepatorenal hemorrhagic fever. It ends, looks like a question mark. And when you ask people questions, that is interrogation. So the name of the bacteria is Leptospira interrogens. All right. What do we do for it? What is the standard? We do MAT. Cat sat on a mat with my brother Lee. So MAT is Lee. Microscopic agglutination test. What is this? This is the EMJH medium. Ellingson, McAuliffe, Johnson, Harris, in which we see the Dinger's ring. We see the Dinger's ring forming. And what is Andaman? So this is also called as Andaman hemorrhagic fever, right? So I hope these flashcards are going to help you. So we are out of time and going to finish the class right here. All right. What I want you to do is I want you to go and look at the rickettsial group. Just to make your life easy, I am telling you that the rickettsial group has also been discussed in FARRE 2025. FARRE 2025 lecture labeled as bonus. Last minute mixed bag bonus lecture. Okay, it was a bonus lecture which was the last minute mixed bag topics. Over there, I have discussed the rickettsial group. Along with this, you please read up systemic mycosis yourself. Okay, in systemic mycosis, you have to read about candidiosis, and you have to read about some dimorphic fungi. Dimorphic fungi, which includes histoplasma, blastomyces, coccidioides, and paracoccidioides. And my students would know the mnemonic, hot boys can party. Yes, so please read about those hot boys as well. So that's it in the lecture. Thank you so much for attending. Any doubts, please DM me. Glad you liked the session, Gufran. Thank you so much. Bye bye. Good night.